So, good afternoon to all of you. And what I shall be talking about is ERCP complications. And most important thing is that we all talk about the techniques, the tips and tricks. But when we are starting, we also need to know about is complications because this is what limits your procedure. So, and as we all know that the eyes will see only what the mind knows. So you need to be aware of complications that can occur because of a very good procedure that is ERCP. So the prevention, what you need to do is a safe ERCP. And for a safe ERCP, what you need to do is plan the procedure. So choose your patients correctly. Don't go in for the wrong patients. And especially when you're a beginner, please be very careful in choosing your patients. Don't choose the more complex cases before. Prepare. So preparation, I would suggest that it should always be considered just like any operative procedure, and a checklist should be maintained. And with checklist, the advantage is that there are less chances of missing out on something. So prepare yourself. Then monitoring is mandatory, intra-procedural monitoring, so that you do not miss any of the signs which may cause complications, and as well as post-operative monitoring, because many of these complications manifest themselves in the post-operative period. So post-procedural monitoring is very important. So we will now talk about the complications that can result because of ERCP, and the most common complications are pancreatitis, cholangitis, hemorrhage, and duodenal perforation. And there are some less common adverse effects like cardiopulmonary complications, contrast allergy, impaction of the retrieval basket, and there would be many more as case reports that you would come across, especially when the tertiary level care is given, like more complex procedures are done, like you are doing cancer stenting in biliary cancers and all. So there might be other adverse events, but I would not be dealing with it because this is more for the basic ERCPs. So there would be multiple factors responsible for ERCP complications, like intrinsic risk of ERCP, patient selection, as I said, skill of the operator, then complexity of the procedure. So complexity of the procedure means that besides the patient selection, it is also that, if you're taking up a ERCP on a patient who has undergone a previous surgery like Bilrod 2, then the procedure becomes very complex. So these are responsible for more of the complications that can occur because of ERCP. So these are various studies that have been done, and the overall complication of ERCP can range from 5% to 10%. So here I would discuss one of the case scenarios which has recently happened with me when I started off with a new team, but that's a wonderful team I started with. But this was a 64-year female with diagnosed polylithiasis and CVT calculi with diabetes mellitus and ischemic heart disease with a normal LFT. We took her up for ERCP, and multiple times the pancreatic duct got cannulated and dye was injected. A pre-cut knife was used for sphincterotomy. Post ERCP, there was pain abdomen with serum amylase of more than 1500 and CRP more than 100. So we diagnosed her as post ERCP pancreatitis. Now, here I talk about the patient selection. So there are risk factors for development of post ERCP pancreatitis, which may be patient related factors, procedure related factors, or operator or technical related factors. When we talk of patient-related factors, young age, female genders, suspected sphincter of Oddi dysfunction, recurrent pancreatitis, prior history of post-ERCP pancreatitis, and patients with normal serum bilirubin. Then the procedure-related are multiple pancreatic duct injections, typical cannulation, pancreatic sphincterotomy, precut access, and balloon dilatation. And operator or technical related factors are inadequate training or experience and trainee involvement in procedure. So in this particular patient, she was female with a normal serum bilirubin, multiple pancreatic duct injections, had a difficult cannulation and a precut access within. So there were multiple factors predisposing this patient for having a post-ERCP pancreatitis. I also suspected a bit of sphincter of Oddi dysfunction, but definitely I did not have any proof for it. But this is what you have to do. And when I talk about multiple pancreatic duct injections, beside the multiple pancreatic duct injections, what you also need to remember is that don't push the dye under pressure, because that also causes hydrostatic damage. And for difficult cannulations, you can try various techniques, like, there are double wire techniques where suppose you're continuously going into the pancreatic duct, use a different wire, and this would help you get into the CVD. When we talk about post ERCP pancreatitis, it is one of the most common complications after post ERCP with a reported incidence of 4 to 31% in various studies. And still date, the mechanisms leading to post ERCP pancreatitis are not fully understood and are really complex. But post ERCP pancreatitis should be suspected in any patient who is developing pain after 6 hours of the procedure, because the post ERCP pancreatitis is less likely to develop after 12 hours from the procedure. Amylase or lipase greater than 1000 is strongly suggestive of pancreatitis, and values of amylase greater than 276 and lipase greater than 1000 obtained after 2 hours after the procedure has almost 100% positive predictive value for post-ERCP pancreatitis. Now here what you need to remember is that most of the patients post-ERCP have a little transient hyperamylasemia. But what you need to be treat is that, okay, patients with biochemical evidence as well as clinical signs and symptoms. These are the patients you have to treat with as post-ERCP pancreatitis. And if you are in diagnostic doubt, radiological imaging can be done to confirm. So because we know that this is so common, so there should be aim to prevent the post-ERCP pancreatitis, especially in the high-risk patients. So there are two ways you prevent it. One is pharmacological and the other is stent and guide wire. So for pharmacological, the drugs that are used are those that decrease, the 5 groups are used, those that decrease pancreatic inflammation like antioxidants, antibiotics, steroids, and NSAIDs. And NSAIDs have been found to be effective in prevention of post-ERCP pancreatitis like endomethacin. The drugs that decrease sphincteropodi pressure like nitroglycerin, nifedipine, botulinum toxin, those drugs which attenuate systemic inflammation like heparin, gabaxate, ulinistatin, and the drugs that decrease pancreatic stimulation like somatostatin, octreotide, calcitonin, glucagon, beta-carotene, and drugs that interrupt the activity of proteases. But besides the NSAIDs, none of them have been found to be independently effective, and multiple RCTs are still required. Stents and guide wires have been found to be effective in post-ERCP pancreatitis, especially in settings like sphincteropodi dysfunction, difficult cannulation, balloon dilatation, that is balloon sphincterotomy, and pre-cut sphincterotomy. And at present, there's a trial that is going on, that is SVI trial, which is stent versus indomethacin, and we would soon have the results to know which one is better to prevent ERCP pancreatitis. As far as treatment of post-ERCP pancreatitis is concerned, it would be similar to treatment of any other pancreatitis. And here, what you need to be very careful about is adequate hydration of the patient. And I would suggest that in patients who are high risk already for developing post-ERCP pancreatitis, give them a proper pre-procedure hydration with ringer lactate. And that has been seen to reduce the incidence. So no harm in doing that. And hematocrit is supposed to give you a very good idea of the hydration of the patient, and maintaining the hematocrit in the normal range should be your aim in preventing these patients post-ERCP pancreatitis. And again, I'm not going into the details of management of post-ERCP pancreatitis, because as I said, it is similar to any other pancreatitis, and if the patient has developed the severe form, then you may have to go in for endoscopic intervention or surgical intervention as well. This is a second case where a 58-year-old female with obstructive jaundice secondary to periampullary carcinoma, that was distal cholangiocarcinoma, with a serum bilirubin of 30 with deranged coagulation profile, was admitted to our ward, and we corrected the PT-INR after giving vitamin K and FFP, and her INR was in the range of 1.6 when we took her up for procedure. We just planned a simple ERCP stenting because she was very sick, and we were just trying to give her some palliation by bringing down the jaundice. And ampulla was cannulated, sphincterotomy started, which was difficult, and there was a sudden give way feel of the scope. And then I realized that this was a perforation. And this was a Stapfer type 1 perforation, and I would discuss what is Stapfer type 1 perforation. And the advantage of a surgeon doing this was that I immediately converted it into a laparotomy and did a duodenal perforation repair with suture repair and omentopexy. However, since the patient was very sick, she was not able to make it. But it was great learning, because this was the first perforation I have ever had in my ERCP over the last 10 years. So as I mentioned that it was a Stapfer type 1 perforation, there are 4 types of Stapfer perforation, type 1, 2, 3, and 4. So there are multiple other systems of ERCP perforation classification, but Stapfer is the most commonly used. And the type 1 is lateral or medial duodenal wall perforation, which is mostly endoscope related. Type 2 is periampullary perforation, which is sphincterotomy related. Type 3 is ductal or duodenal perforation due to endoscopic instruments. And type 4 is guide wire related perforation with presence of retroperitoneal air at X-ray. So more than managing the perforation, it is very important to recognize the perforation. So recognizing the perforation during procedure is very important. And if you're getting a wedge-shaped lucency like this, then do keep your suspicions very high. Do treat these patients as perforations. So when we talk about management of ERCP related duodenal perforation, in a systematic review, it was found that the incidence ranges from 0.09 to 1.67% with a mortality of 8%. And early surgical intervention is in Stapfer type 1 has better outcome, while conservative treatment is recommended for Stapfer lesions 3 and 4. The most common is Stapfer type 2 perforation, followed by type 1 and then type 3 and 4. It has also been seen that if you are going in for surgical intervention, if you do it within 24 hours of the ERCP, then you can, go away with a simple duodenal suture or with or without immunotoxicity. But if you take it up later, then the complications are more, and also the procedures that you will have to do are more complex. Like you may have to do a bypass resection or whatever. It would be a more complex procedure. This is a picture showing that patients with perforation at times can also dealt with by endoscopic clipping of these perforations. Another common complication is bleeding in ERCP, and it is most frequent after endoscopic sphincterotomy, and it's found in about 5% of post ERCP or ERCPs. The rates of post sphincterotomy bleeding vary widely, and its presentation may be either immediate, that is intraprocedural, or several days later. And bleeding can range from insignificant to life-threatening. Causes will be patient-related, like if patient has bleeding disorder or his coagulation profile is deranged. Procedure-related, like endoscopic sphincterotomy, which is the most common cause. It can be wire injury to CPT, or also the type of energy used. And here I would suggest that mixed and blended energy is what reduces the bleeding. So if we look at management of bleeding in ERCP, it again would depend on when the patient has presented with the bleed. So if it is like a hemophilia, you have to manage it just like any other GI bleed. But if you have found it on table, then there would be endoscopic treatment that you should do. And the first of all would start off with, you should not like, you see bleeding and you stop sphincterotomy. No, complete your sphincterotomy. The reason for completing the sphincterotomy is that the vessel that has started bleeding will not go into spasm if you leave it halfway. It will not retract. So if you complete the sphincterotomy, there is a chance that the vessel goes into spasm, retracts and goes into spasm, and the bleeding gets controlled. So that is the why you should complete your sphincterotomy. And the second is you can use mechanical methods like, you can use a sphincterotomy balloon where you can use it as a tamponade. Put in there, inflate the balloon, pull the endoscope, just shorten the endoscope and leave it just like a tamponade in any other surgery. Leave it for 5 minutes, come back and see. Mostly it should get controlled. If it doesn't, then options available are thermal or injection with adrenaline, that is 1:10,000 dose, or you can also use clips at times. Refractory cases, you might have to go in for angiographic embolization or even surgery. Another complication is post ERCP cholangitis, and in one of the retrospective studies of more than 4,000 patients over a period of 5 years, overall complication rate was 9.4% with a post ERCP cholangitis range of 2.4%. And the most dangerous time for developing post ERCP cholangitis is within 24 to 48 hours, and more than 45% of cases occur within this period. The risk factors associated with development of post ERCP cholangitis are age, hypertension, diabetes, previous ERCP history, biliary stent insertion, pancreaticography, endoscopic sphincterotomy, balloon dilatation, and hilar obstruction. On the other hand, endoscopic stone extraction is supposed to be a potential protective factor. And then again, cholangitis has to be dealt with any other like any other sepsis, depending on the whether it is just a Reynolds pentad or a Charcot's triad, and you have to manage the patient accordingly by giving hydration, giving antibiotics, monitoring pulse, BP output, everything. There would be some unusual complications that you would come across, like stuck dormia, that is impaction of dormia basket when removing the stone, which is an unusual complication. And here, just as a guide, if you are dealing with a very large stone, more than 1 centimeter, so you need to remember that these stones, you should have a lithotripsy if you're trying to take them out, because the sphincterotomy that you do is usually 1 to 1.2 centimeters, and larger stones, it would be difficult to retrieve them that way. Always better to have a lithotripsy in such cases. Only then you should attempt taking out such large stones via ERCP. And if it is stuck, if it is a surgeon doing it, you can convert it into laparotomy and take it out. Or if it is a gastroenterologist doing it, then you have to cut the dormia basket, send the patient to a surgeon, and then take things from there. There are multiple ways: open surgery and also laparoscopic CBD exploration can provide an alternative therapy. And this is a photograph of one of the stuck dormia being retrieved laparoscopically by laparoscopic CBD exploration. So when I talked about for complications, prevention of complications is a better way than to deal with the complications. So choose your patient rightly, and remember that ERCP is most dangerous for people who do not require it. So who are the patients who don't require it? Patients with vague abdominal pain, isolated bile duct and pancreatic duct dilatation, isolated increase of amylase lipase, and non-availability of MRCP or EUS. These should not form indications for your ERCP. So I would like to end with a note from Atul Gawande's Complications, a surgeon's notes on an imperfect science. So no matter what measures are taken, doctors will sometimes falter, and it isn't reasonable to ask that we achieve perfection. What is reasonable to ask is that we never cease to aim for it. So I would suggest that all of you should reduce the gap of your knowledge by reading more about it, knowing more about the techniques, tips and tricks, and then knowing about the complications and how to prevent them, so that the gap in the knowledge is not there and you can aim for doing a complication-free procedure. Thank you very much for your patience, Yuri. Thank you.